I want to introduce our last speaker. We have this great opportunity. When we were talking with Dr. Pan's office, they said, well, he could come in the latter part of the day. And I thought, wow, we could start with Senator Steinberg and end with Assemblymember Pan. How perfect is that? So we're really happy to have him here. I want to tell you a little bit about his background. And again, they don't print these big enough for me to read anymore. So Dr. Richard Pan is a UC Davis educator, and he's a pediatrician. He was elected in 2010 to represent the cities of Sacramento, Citrus Heights, and Folsom, and you have a number of your constituents sitting here in this room. So he's done a number of things that are just incredible as I'm looking at the things that he's done around improving health for his community. He was the director of the UC Davis Pediatric Residency Program, and as a part of that, he created something called the Communities and Physicians Together to make UC Davis medical students available to neighborhood associations who are working to improve the health of their communities. He is also the co-founder and chair of Healthy Kids, Healthy Futures. He helped to secure health, dental, and vision coverage for over 65,000 children in Sacramento, Colusa, El Dorado, Placer, and Yuba counties. And I served on the Placer County First Five Commission, so I'm certainly very aware of that. We were really pleased to be involved in that larger collaborative. He helped to create the Sacramento Health Improvement Project, bringing together doctors, hospitals, clinics, and community leaders to ensure that all Sacramento County residents have access to primary health care. He also served on the United Way California Capital Region Board, the Board of Blood Source, and the Sacramento First Five Commission. I'm not sure when he had time to actually be a physician with all of that, but that's a lot of community involvement. He has been honored with the Campus Compact's 2008 Thomas Ehrlich Faculty Award for Service Learning. He was also awarded the 2010 Physician Humanitarian Award from the Medical Board of California for his work as a pediatrician, professor, and community advocate. And I could go on, but I think that gives you a picture of how involved he's been with his community prior to being elected. And the fortunate thing for us that he is now the chair of the Assembly Health Committee. So, you know, hopefully we have the opportunity to see that same spirit, that same collaboration and development for the whole state, not just this area. So with that, Dr. Pan, if you would.
Thank you so very much, and it's a real privilege to be here today, and I appreciate this opportunity to talk to all of you. Yeah, I did actually have time to practice quite a bit of pediatrics. I will tell you, since you're mental health professionals here, actually my clinical focus is on children with learning disabilities and behavioral problems. I particularly worked with children who had ADHD, who had other mental health issues, mainly with kids who are in the Medi-Cal program, foster care, so forth. In fact, also partnered with schools to try to figure out how can we bring the education and medical communities together, healthcare communities together to try to better manage these conditions that children had, and then certainly at least on the primary care end, and we'll probably touch a little later on integration of primary care and mental health, but and of course recognize the very important role all of you play in being sure that these kids get the mental health services they need. And I'll tell you that one of the things that actually drove me eventually to run for public office, because I wasn't planning on a career in politics at all in my life, was that I had children who I took care of in my practice who, when the county was cutting back their mental health services, were being basically shifted from one provider to another. And I remember a family coming in to me and saying that, you know, this is a child who's had mental health issues for, you know, he was about 12, you know, they've been in treatment for almost a decade, who we knew what the problem was, we knew what the treatment was, and was told that because they were shifting from one agency and one group to another because of the cutbacks, that they had to wait to be reevaluated, and while they're waiting for the reevaluation, would not receive any care, and that this would be scheduled 6 months from then. And the parent came to my office and said, "What am I supposed to do? You can you do this for me? And I said, I'm not a mental health professional. I'll try to do what I can. I'll try to keep the meds going and stuff like that. But I'm not a therapist. I'm not a, your child does need someone mental health professionals to keep following, and I will support and assist them. That's been my role. That's the best role I can play. But I guess I am the person who's going to be the temporary bridge, but this is really not right. This is not the way we're going to help take care of it. And we certainly know the consequences, unfortunately, is that when these kids are also adults who don't get the care, and then they get in trouble, and they end up in the hospital and clog up emergency rooms. Police officers get called when things happen in the home, and then public safety gets involved, and there's a tremendous cost to, of course, we know the family and the patient, and that's really still the most important, but also a cost to the neighborhood and society. So we really do need to address these, try to figure out better solutions to these. Now, what I did want to talk about is that the big thing for the Health Committee is the implementation of the Affordable Care Act. While there's certainly many other issues, I mean, this is a very exciting time. This is a very transformative time in healthcare, and including mental health, the Affordable Care Act. And there are very more important elements in the Affordable Care Act that in relation to mental health and substance use services. We have passed a bill, we now have a law in California that requires mental health and substance use services to be covered as essential benefits in covered California or health benefits exchange. And both the sort of commercial small business market, as well as we'll have it for individual purchasers as well. So certainly we recognize how important and how integral behavioral health is to overall health in the benefit designs for the exchange. Certainly from my perspective as a pediatrician, these essential benefits are a significant step forward for children's health. I'm also pleased that regulations for plans offered through Covered California include strong benefits for children, including vision, comprehensive dental, mental health, and access to pediatric specialists. Unfortunately, we also know, though, that the plans participating in the exchange will not be required to adhere to the full EPSDT, early periodic screening diagnostic treatment services, which are offered in Medi-Cal, and due to cost concerns. And certainly that's a program that I'm very familiar with as a pediatrician in terms of its, at least nationally, how it ensures that children can get appropriate health care coverage. We also have the expansion of Medicaid, or Medi-Cal, in 2014 to include all individuals below 133% of federal poverty. And I heard the previous question about that. We're going to try to make access to more affordable coverage is going to, again, try to reduce the number of uninsured patients and actually have a positive effect on trying to reduce unmet health needs and increasing receipt of preventive and less costly care. But one of the things that's going to happen is we're doing this. We talk about we're working on the bill. In fact, next week we're going to have hearings on the Medi-Cal expansion bill. We're going to be talking about the individual market reform bills. And people talk about 2014, January 1st, 2014, we're going to have these things in place, and the exchange and the Medi-Cal expansion. But we have to realize that one is that as much as some of us may be aware of that, the general public is not quite as aware of that. And I think there was the discussion about yes, it's fully funded for the first 3 years, but it's going to take us at least a couple years to get people to know this is happening. So even in terms of the uninsured, there's still right now we have a lot of people who qualify for Medi-Cal who are not on Medi-Cal. They qualify for it. In fact, one of the things the state's looking at when we're looking at the state budget is that some of these people actually, which I think is a good thing, there are some, is that they'll say, oh, yes, I should enroll. And those people, of course, will have to pay 50% for it as a state. They're not part of the expansion population. But that is a state cost that we have to work into the budget. But I think it's a good thing they're getting coverage. We need to get more people coverage, more people in the system. But so for the counties who are going to still be having the responsibility of being essentially the provider of last resort, you're still going to have people, even if they qualified expansion, and I know that certainly we're going to work with every county to be sure that we try to get as many of these people enrolled in as possible, they're still going to show up for care in emergency rooms and other places, and maybe your doorstep, and that we're going to try to get them enrolled, but still, you're still going to be using some of that county money to take care of them until you figure that out. And so we realize, I certainly realize that there's going to be some time that we're going to take to be sure we get people plugged in to their appropriate source of care, into a regular source of care, and that we need to recognize that there is going to be a transition time. And also that as we're implementing these things, we're taking our best guess as to what's going to happen. We're going to need some transition time to also figure out adjustments we need to make and so forth, to figure out where are we really going to be when things sort of settle down. So I think that's a very important part in terms of the Affordable Care Act. But there are tremendous opportunities, and certainly very excited to work on them. Again, I mentioned that next week we're going to have the special session hearings. We're going to have a hearing on the Medi-Cal expansion bill that the Speaker has authored on Tuesday. We're going to be doing a hearing on the individual market reform bills on Wednesday. I think those of us in the legislature have a little different idea than the administration about the Medi-Cal expansion, which I know he put in those options in the budget. That's not what, we don't have those things in our Medi-Cal expansion bill. We'll of course be working with the administration as well. We need to work together, but we have been hearing, certainly many of the concerns have been raised about the 91 realignment and so forth, and we want to try to be sure we work that out in a way that really makes sense for the people of California. So again, looking forward to seeing what kind of opportunities we can, that we're going to have through the ACA to really expand mental health coverage, substance abuse coverage for services, and then we got to figure out how to make this, how to try to do this right. And I guess I just want to sort of close on saying that you're the ones, as a physician, I know that that there are things that I see on the ground that I'm going to have to work out. And all of you who are on the front lines are going to be figuring out how to make this thing work. In some senses, we can't legislate all those details in the legislature, but what we need to try to do is create an environment in which you can be successful in coming up with your innovations, recognizing there's local differences and so forth, being successful in taking care of the patients that you're taking care of. And we need to try to have policies in place that allow you to be successful in doing that. And so what we want to do is hear from you about what are things we need to try to do, but also what kind of space we need to give you in order to try to develop the kind of new different models of care that can be more successful, that can integrate more care. Let's figure out how can we try not to create this divide between mental health on one side, physical health on the other, because we know they interact with each other. And so what are ways we can try to better integrate care and really try to improve not only the quality of care, but ultimately the health, and including the mental health of Californians as we go forward. So again, appreciate this opportunity to talk to all of you, and actually also want to take this opportunity to take questions. So thank you. Thank you so very much for having me here. Thank you.
Hi, Dr. Pan. Tom Renfrey with the County Alcohol and Drug Program Administrators. A question about parity. We've had the federal, Mental Health Addiction Equity Act now for about 4 years, and the enforcement of it has been somewhat spotty. I mean, there's a lot of consumers and providers who don't really know what parity means. The health insurance plans seem to know what it means, but are doing everything they can to find loopholes or somehow to get around it. So it has not been, in our view, has not been as effectively implemented as it should be. Senator Jim Bell has had a bill for I think 6 years, that he's trying to implement state parity law, and that's again been stopped every time by the opposition of the insurance industry. My question is, do you think has there been discussion in the legislature about kind of going to the mat on this parity issue and holding plans accountable to make sure that they enforce this?
So you bring up a very important question, and I'm proud to have supported now Senator Beal, when he was Assemblymember Beal, in his quest to get mental health parity. One of the things that when I look at the healthcare market is that when we talk about trying what's the incentives in the environment, one of the challenges that I recognize as someone with a background not only in medicine but in public health is that people with mental health conditions also are more likely to have physical health conditions. This creates a adverse selection risk issue for the plans, which actually is a strong disincentive to plans to actually provide high quality mental health services. Because what happens is that if you're the plan with the best mental health services, you attract people with mental health problems to your plan. Even if that's carved out as a separate risk pool, you drive up your physical health costs. So one of the things that also we've been looking at, while it may not seem to be related to parity, will hopefully also create conditions that will make plans more interested in addressing mental health issues, is really looking at what we call risk adjustment, which is that, so instead of saying that you get the same amount of money for every person that's in your plan, because basically then what happens, you try to find the healthiest people, right? Because they'll cost you less, and then keep the sick people out, that actually there's mechanisms in which plans that have a higher risk pool, which includes people with mental health, actually get more payment. So you basically tell the plan, and there's different mechanisms to do it, but you can tell, a plan that has a higher proportion of healthy people would be required to pay into basically everyone would pay into a pool, and then if you had a higher proportion of sick people, you'd actually get more of the money. And the people who basically were more cherry picking, you get less. And therefore decrease, at least try to decrease, if not try to eliminate, the financial incentive to play this game. And so instead, that the way you'd be successful as a plan is not to run away from people when they have illnesses, including mental health, that they would actually make more money by providing better service and more cost-effective way, and you can make more in that margin. And in fact, to that end, I have actually already held 2 informational hearings, one on actually risk pools and risk adjustment, as well as one on the patient-centered medical home and chronic disease management, and with a particular actually interest in people recognizing that we need to do a better job managing chronic illness. That includes mental health. And while I think it came out in the hearing that there's not good data in the chronic disease community on clearly mental health is a chronic condition. So so certainly I strongly support mental health parity. I'd love to work with you and of course Senator Beal on trying to see what we can do to get that through. And also wanting to work on what are mechanisms we can, because even if we get a mental health parity law passed, I also want to take away the incentive for essentially plans or risk-bearing groups to basically run away from people with mental health diseases. I want them to embrace them and say, you know what, I want to take this on and figure out a way to do it better. If I can do it better, that's how I'm going to be successful. And then that means that the patients will get better care, and that will put competitive pressure on the other plans to actually provide even better services, instead of everyone trying to provide who can provide the worst services so someone else will take them and they'll run away to somebody else. That is exactly what's wrong with our healthcare system. With that, thank you. Yes.
Assemblyman Pan, I'm Pat Ryan with the California Mental Health Directors Association. I first want to thank you very much for your leadership and for understanding and obviously caring about the issues as much as you do, and you come from a place where you actually understand those issues at the patient level. So, whatever we can do to support you and continuing to be a leader in mental health, we really want to work with you. But the point I was going to make is that you made a reference to the cost of the state in enrolling people who may end up being eligible for our current mandatory what's being called our current mandatory population. And I just want to make sure you and other legislators know that because the specialty Medi-Cal mental health system has been carved out, and drug Medi-Cal systems have been carved out to counties, to the extent that we identify new enrollees at the 50% match population, we're at risk for covering them. So, at the same time that the state is concerned about the risk that they have in more costs for the non-expansion population, we have the same concerns. So we need to figure out how to pay for that as well.
Sure, and and so I mean, I think those are certainly. I appreciate you bringing that up, and those are concerns on the financial side. I would also point out, and we need to figure out how we support you and counties in trying to take care, providing that care. We know it's the right thing to do to get them to care, right? We need to figure out. One thing I do want to point out, though, is when we talk about the Medi-Cal expansion, is that it's going to bring in probably initially $2.5 up to $4 billion a year into the healthcare system, all right? Because as people, in the beginning, it's going to be lower because as we get more people to recognize they need to get enrolled, and we get them more enrolled. So that's a financial stimulus. It's going to create, estimated, there was an economic study that showed almost 100,000 new jobs in the state of California. So, there's going to, and we won't talk about, every time someone wants to build a stadium or something to talk about, then they talk about the ripple effect. Well, let's talk about the ripple effect of bringing in, $5 billion and 100,000 new jobs with people who are then going to go out and go buy groceries and do other things. I mean, so we need to think about that as we're doing the Medi-Cal expansion and say, some of that, and we're going to be generating more revenue and economic activity, and how do we take some of that and reinvest that and be sure we cover, use some of that to help fill in the fact that the gaps that we should be paying for, because these are people who need the care, and that actually it's more, and it's cheaper in the long run to actually get them the care now than to keep putting them off. So while we're all looking at our individual silos, we need to step back and figure out how can we then support counties and county mental health departments, as well as the other entities, in trying to be sure the goal is worthy. We need to do it. Let's work on figuring out the financing there. Thank you. Thank you.
Great, thank you, Scott Grundle-Glenken. I really appreciate all your comments this afternoon. I really get motivated when we can start having discussions about how we share in the savings, the end game of healthcare reform, because that's really what's motivated all the work that I do at the local level. And my systems are integrated primarily so that I can be competitive, that I can partner with the private market, that I can bring products that the private market doesn't have. So to expand on that, I honestly believe that whole health includes employment and income and housing and food security and community development, getting communities to invest and build in themselves and not having government step in and necessarily take care of that. All of that comes together to result in creating that savings. And so I really look forward to when we can talk about how we're going to divvy up the savings instead of having this discussion about who's going to take the money up front. So thank you. Well, thank you for that comment. And, I think that one example that speaks to what you just said is that I was involved, so we talked about the Sacramento Health Improvement Project. So that was a coalition we brought together in Sacramento County to look at the safety net. And part of what prompted that coming together was there was a study that was funded in Sacramento by some foundations called the Frequent Users Project. And the Frequent Users Project was looking at people who are frequently using the emergency room and what can we do to reduce emergency room use. Now, interestingly enough, the people who used emergency room frequently, it wasn't just because they were uninsured. In fact, many of them were insured. And so when people started digging into the root of the problem, certainly they had health care issues. They also had mental health issues, and that's part of what brought them to the emergency room. But fundamentally, the reason they became frequent users were because they didn't have housing. They didn't have stable housing. They were homeless. They didn't have stable housing. That was actually what best defined why they used the emergency room frequently. So what happened is that you were in an emergency room, you could sort of patch things up a little bit, and then you'd send them home, and they really didn't have any place to go to. They didn't have an anchor to get additional services, to help people coordinate services and so forth. So as we're looking at trying to how do we improve healthcare costs, reduce unnecessary ER use, things like that, we do need to look at this larger picture as well, and how do we try to link, not think about healthcare, our mental health care simply in isolation. I know that all of you don't. You realize these things, but how do we cook it together? When we look at the Wagner chronic care model, we talk about chronic care. There's the chronic care model is there's definitely an element in terms of community and how do you plug someone into both community services and community supports? Because without community,
those type of services, those types of supports, again, sometimes it's very hard to maintain the kind of care that you need to maintain. So we do need to, when we look at this, I realize for the dollars and cents sense, things can get a little challenging. But I mean, at least when we look at these models of care, we do need to recognize that, you know, all the different parts of our lives are interconnected together and they affect each other. No. Any other questions? Yes.
Hi, Kristen Jacobson, the Alliance of California Autism Organizations. I just wanted to add something to Thomas's comment about mental health parity, and I'm very pleased to hear that you're a supporter of mental health parity and expanding it beyond just the severe mental illnesses, which is the only group in California that has mental health parity. The other piece that I would love to have you address is the exemption for Medi-Cal managed care plans for the mental health parity law, so that we have mental health parity for severe mental illnesses for the population that has private health insurance, and we will have it through Covered California. But if you are a Medi-Cal and probably the most needy population in the state, there is no parity at all for any condition. So when you look at expanding it beyond severe mental illness, I would also love to have it considered to expand parity to individuals enrolled in Medi-Cal managed care plans.
You know, fortunately, politics is the art of the possible. I fully support getting mental health parity, including in Medi-Cal. I supported Senator Steinberg's bill for in terms of treatment of autism, you know, the mandatory coverage of autism, which unfortunately was only for private plans. Now, you know, I take care of mainly, I was, you know, 60, actually right now, I still practice, by the way. It's a community health center, so it's all Medi-Cal and uninsured, but before when I was at UC Davis, I was about 60, 70% Medi-Cal patients, and had some patients with autism. And so when I looked at that bill, I said, well, on one hand, it wouldn't, you know, it doesn't apply to the patients I took care of, which is very frustrating. But if I wanted to at least make a statement and get the bill to move forward, you know, this is the best we could get, because given their budgetary situation would have died otherwise.
We agree.
Yeah, I know. And so unfortunately, sometimes we're forced to, but I agree. This is not the situation. This in my mind, hopefully, is a very temporary situation that once we can get more resources. And yeah, why should we be exempting our public programs from this? And after all, that's the population I take care of. That's the population I know has actually the greatest need for the parity, and yet at the same time, you know, we don't have that. So you know, there is always more work to do.
Right, and we understand that there always have to be trade-offs and a step at a time.
Right.
But in terms of, you know, now that we can look a little further ahead and we're not in I can't even spend a penny today because, you know, we're completely bankrupt. Long term, there will be great savings for providing the mental health services to the Medi-Cal population as well.
Thank you.
Thank you very much for raising the issue of the Frequent User Initiative, which I remember very well being on their advisory board for 5 years. There were two major learnings, though. One was the housing learning. The other was care coordination and service culture. Improvements in service culture and care coordination stopped a lot of the frequent users right in their tracks because somebody finally paid attention to them, and rather than the episode of going to the hospital.
Right.
So, and that's the piece where I think the behavioral health community is much better at care coordination and much better at improving the service culture than the physical health care side has been.
I appreciate you mentioning that. Actually, one of the interesting results of an intervention they tried to do in the Frequent Users Project was initially, so they looked at this, they did the study. We actually started locating some social workers and so forth to do more coordination in the emergency room. Turned out that what happened is then people started viewing the emergency room as their primary care site, because that is where they were getting the help for it. So the next iteration, at least in Sacramento, is that with the establishment of the effort as a FQHC is that now what they're doing is they're literally saying what we want to try to do is when the patient shows up in the emergency room after we stabilize them, we actually take them by hand, because you can't just discharge them, tell them follow up at this clinic they've never been to. Actually, literally take them by hand to the clinic and say, here you go, and then you have the coordination services right there, and then of course discharge them literally, practically from the clinic itself. I mean, you kind of paper discharge them out, but you don't let them go until they actually show up at the community health center, where they do also have mental health services as well, and so that they start identifying that as being their usual source of care site. But no, I appreciate you bringing up that was also a very important finding in the study they were looking at. So thank you.
Hi, my name's Wayne Clark, and I'm the Director of Behavioral Health in Monterey County, but also the President of Cal Mesa, which has a large prevention and mental health promotion campaign going on in the state of California. Yesterday, UCSF released a study of the 20-year impact of the smoking cessation projects in the state. A $2.4 billion investment has resulted in $134 billion savings. And I think that the legislature should be, as the ACA does, be focused on prevention as well. We look a lot at mental health promotion, and mental illness prevention is a very important part of any healthcare delivery system. So any activities that the legislature can be doing that, I think would be appreciated.
Well, thank you. And part of the challenge of prevention is that when you prevent something, some people don't always know you prevented it, right? How do you count that? But exactly what you saw with tobacco, and we need to do more of that. So you know, we need to try to move away from this kind of constant, you know, trying to bat down problems after they happen and getting ahead of them. So yeah, tobacco's been a great example for California, and we need to expand that model to a lot of other things. Thank you. Well, thank you so very much again for having me here. Look forward to working with all of you, and thank you for everything you do for the people of California. Thank you.